Hello, my name is Michael Trower. I'm an emergency medicine consultant, and today I'm going to show you how to do a AAA scan. So what is a AAA? Well, any arterial aneurysm is defined as 1.5 times the normal diameter of that vessel. And the aorta is normally 2 centimeters. Therefore, a AAA is anything 3 centimeters or more. And you can remember this because AAA has 3 A's, so 3 A's, 3 centimeters. However, it's unlikely for AAAs to rupture below 4 centimeters, and the risk of rupture increases significantly once they're above 5 centimeters. So this is why at this point is where elective repair is considered. So AAA is a disease of older people. It's quite common, about 5% of over 50-year-olds. And it occurs much more frequently in men than in women, about 4-to-1 ratio. And so for these reasons, there is an ultrasound screening program for males over 65. So how does a ruptured AAA present? Well, classically with sudden abdominal flank or back pain, or possibly without any pain and just with syncope or hemodynamic instability. What's the anatomy of the abdominal aorta? Well, the IVC enters the abdomen at around the level of T8. The aorta enters a little lower down at the level of T12, and then bifurcates at the level of the umbilicus in L4. So now if we zoom in on the abdominal aorta, as you can see there are lots of branches. Now you don't need to know about all of these, but if you do have some understanding, it will help you distinguish the aorta from the IVC. So the first main branch is the celiac axis, which comes off just after the aorta enters the abdomen at the level of T12, and it has 3 branches of its own: the hepatic artery, the left gastric artery, and the splenic artery. The next branch is the superior mesenteric artery, or the SMA, which comes off just a centimeter or 2 below at the level of L1. And then the final branching point that you need to know is the bifurcation of the aorta into the 2 common iliac arteries. The other branches, the renal arteries and the inferior mesenteric artery, we don't see so well on ultrasound, so don't worry too much about these ones. So this is a scan of the upper abdomen. Always start at the back of the image by making sure you can identify the vertebral body. Then we have the IVC to the right of the midline and the abdominal aorta to the left. And you can see coming from the abdominal aorta is the celiac axis, and the 2 branches of this looks like the wings of a seagull. Now a little bit lower down, this is the level of L1. Again, we start with the vertebral body at the back. We have the IVC to the patient's right and the aorta to the patient's left. Just above this is the SMA, and these 3 structures, the vertebral body, aorta and SMA, are sometimes referred to as a snowman, with the vertebral body, the body of the snowman, the aorta, the head, and the SMA, the little hat on the top. The other structures we can see are the portal vein, the pancreas, the liver, and also running between the aorta and the SMA, you can just see the left renal vein running down into the IVC. Here's a diagram showing the same thing. So from the top down, liver, pancreas, portal vein running behind the pancreas, SMA just behind that, the left renal vein running between the aorta and the SMA, and then the aorta at the back, just in front of the vertebral body. Okay, so now we've slid all the way down to the umbilicus at the level of the bifurcation. So again, starting at the back, we have the vertebral body. To the right of the midline, the IVC, and now the abdominal aorta has bifurcated into the 2 common iliac arteries. So here we've rotated the probe through 90 degrees, so we're in the long axis, so with the probe marker to the patient's head. So at the top of the image, we have the liver. Deep to this is the aorta, and you can also see the SMA, which branches off the aorta and runs along parallel to the aorta and just anterior to it. So how do we scan the aorta? So choose the low frequency curvilinear probe. Start with the probe in a transverse orientation with the marker to the patient's right, and then scan down continuously all the way from the xiphisternum down to the umbilicus. Then rotate the probe into the long axis with the marker to the patient's head and slide down again. Here is a video of myself scanning my own abdominal aorta. So as you can see, I'm sliding down continuously all the way from xiphisternum down to umbilicus. And I'm trying to keep the abdominal aorta in the middle of the screen the whole time. So I'll just let this video play one more time. So at the top, we can see a couple of branches coming off, and you can see the IVC over to the patient's right. And as we go down, the aorta becomes more superficial, and we follow it all the way down until it bifurcates at the umbilicus. Here is the same thing, but in long axis. So exactly the same thing. We start at the xiphisternum and we slide all the way down to the bifurcation, but this time in the long axis of the vessel. So how can we be sure we're identifying the aorta? Well, first start with sufficient depth to make sure you can see the vertebral body at the back of the image. If you start with insufficient depth, you may see the SMA or the portal vein at the bottom of the image and think that that's the aorta. So always start with plenty of depth, and you can always reduce it later. Distinguishing the aorta from the IVC is also important. So the aorta tends to be to the left of the midline, IVC to the right. The aorta is round and thick-walled, whereas the IVC can be of variable shape and is thin-walled. Bowel gas is the main technical problem with AAA scanning, and it can be a big problem. Sometimes you simply can't get a view of the aorta at all. But there are a few things you can do to try and get around this problem. First, have the patient lie supine with their hips and knees flexed. Apply firm pressure with the probe to try and push the gas out of the way. If this doesn't work, slide the probe slightly laterally and angle back towards the midline to get around the gas. If this still doesn't work, slide the probe more laterally, so you're right on the side of the patient, and use the liver or the kidney as a window. Failing this, have the patient take a deep breath in, so the diaphragm will push the gas down out of the way. And if all of this has failed, take a deep breath, leave the machine by the patient's bedside, come back in a few minutes, and hopefully the bowel gas will have moved on. Having said all this, if you can't get a view of the aorta and you really need to know whether there is a AAA, you'll just have to get a CT scan. How do we measure the aorta? Well, in transverse, first make sure that you're perpendicular to the vessel. If your beam is at an angle, you'll get an ellipse rather than a circle, and this will overestimate the diameter. If you're in long axis, make sure you're scanning through the middle of the vessel. If you scan to the side, you'll just be measuring the edge, and so you'll underestimate its diameter. And finally, include any hematoma in your measurement. So in this image, there is a large hematoma, and you can see if we did not include that in the measurement, we would grossly underestimate the size of the AAA. So how do we interpret our findings? Well, assuming we can get a good view of the aorta, it's a very highly sensitive and specific test. So it can both rule in and rule out a AAA. However, it won't tell you whether this AAA has ruptured or not. If you imagine you have a man who's presented with sudden abdominal pain and hypotension, and you see a 12 centimeter AAA, it's pretty likely this has ruptured. On the other hand, if you have a patient who's presented with some non-specific dizziness and looks very well and has a 3.1 centimeter AAA, it's very unlikely this is ruptured. However, the only test that will actually tell you whether a AAA is leaking or not is a contrast-enhanced CT scan. So what are the pitfalls in AAA scanning? As we said, misidentification of the aorta. So as we said, make sure you start with sufficient depth and discriminate the aorta from the IVC. Mismeasurement of the aorta. So as we said, make sure your beam is perpendicular to the vessel and in the middle of the vessel, and include any hematoma in your measurement. And finally, misinterpretation of your findings. So just because you've seen a AAA, this doesn't mean that it's ruptured. So take-home points. Take care in identifying the aorta. Make sure what you're measuring is in fact the aorta. Try and visualize the whole aorta all the way from the xiphisternum down to the bifurcation. And remember, point-of-care ultrasound won't tell you whether any AAA has actually ruptured or not. If you'd like to learn more, here are a couple of fantastic links. The first one is to a 5-minute video going through AAA scanning, and the second one is a link to a repository of really interesting ultrasound images with lots of examples of pathology. Thanks very much for listening.